حابين نبدأ 10 و5 دقائق ولا أبدأ الآن؟ إيش رأيك؟
ممكن 3 دقايق كده بالظبط ونبدأ يكون.
أي.
تمام، نقدر نبدأ يا دكتور إذا حابب.
طيب، ممتاز. السلام عليكم ورحمة الله. صباح الخير جميعا. It's my pleasure to be one of presenting a topic in this academic activity. I'm Dr. Ahmed Al-Bloui, Pediatric Emergency Consultant, ED Lead, and Head of ER Department in MCH Hospital. Today we'll talk about status epilepticus in pediatric age. طبعا في البداية حاب أهني الجميع، آه، وجميع تيم الطوارئ، وأخص بالذكر من ساهم بعد الله سبحانه وتعالى في اعتماد البورد السعودي للطوارئ الكبار. آه، للأمانة إنجاز كبير المفروض كلنا نفتخر فيه ونسعى جميعا إنه إحنا نبنيه بطريقة أفضل، وأهمها الحرص على حضور الأكتيفيتي، حضور المحاضرات، وتبني هذا الموضوع بكل مستشفى وبكل قسم في مستشفيات أو أقسام الطوارئ في تجمع تبوك الصحي. So this is as an introduction, we will just talk about the definition of status, incidence, morbidity, mortality, type of status, differential diagnosis, diagnostic studies, and then finally we will move to medical management and stabilization. So as introduction, the seizures account around 1% of all ED visits in pediatric age group, and they're ranging from the benign condition till reach to the life-threatening event. So we will ask how long do the new onset of seizure actually around they make like a study from age of 1 month till age of 19 years. They found around 76% the onset of seizure they less than 3 minutes. 92% of seizure they are stopped spontaneously. But the longer of seizure that's mean less likely to be stopped without medication. Also regarding hospitalization and length of stay, as we know, the cost-effective, especially outside, is matter for them. So the seizure is the most common CNS and neurological diagnosis that required hospital admission, and this is the sixth disease or diagnosis that might need admission in the United States in 2017. By definition, as we know, the International League Against Epilepsy previously they label status epilepticus when patients reach 30 minutes of continuous seizure activity. Later on, they found as a patient having 5 minutes or more of continuous clinical or electrographic seizure activity or recurrent seizure activity without recovery. This is labeled as a status. Finally, in 2015, also the International League Against Epilepsy reviewed the definition, which is the continue resulting either from failure to mechanism respond for seizure termination or initiation of mechanism which lead to abnormally prolonged convulsion. What about the incidence, morbidity, and mortality? The incidence is high, especially in the neonate age group till age of 5 years of age. Around 75% of first presentation of seizure, they came as a status epilepticus, and 30% of them as a first time of seizure, if came with a status, might lead to be epilepsy. What about the mortality? It's around 3% according to the recent studies. Now we will move to status epilepticus types. We have two types regarding the motor features. We have 4 types, either tonic-clonic, myoclonic, focal, and hyperkinetics, or without motor feature, which called non-convulsive status epilepticus. What about our differential diagnosis? We have a wide differential diagnosis in pediatric age group. We start usually with a metabolic as a differential, especially in inborn error of metabolism, sometime like a hepatic failure or hepatic encephalopathy, infections like brain abscess, meningitis, meningoencephalitis, CNS infection of newborn like syphilis, also congenital anomalies and syndromes like Dravet syndrome, which came with intractable seizures, difficult type of convulsion, oncology patient, tox like anticonvulsant medication and antipsychotic medication toxicity. Also, trauma be considered, start from the concussions till reach to severe head injury. Regarding the diagnostic study, when patient came to our emergency with a status epilepticus, our aim to draw the lab to find the reason or to look for the differential to early intervention. So the American Academy of Neurology practice parameter, they are addressing a diagnostic assessment in children with status epilepticus, and they are reviewing the orders. That's usually order while patient seizing, or they found around 32% they have low anti-seizure medication for those patients well known of epilepsy. And also they found 80% abnormality in neuroimaging, 6% electrolyte disturbance, and 3 to 4% they having inborn error of metabolism, ingestion medications or whatever, CNS infections, and sepsis. What about the routine lab? The Neurocritical Care Society guideline, they are recommended to do a glucose check as initial quick lab within 2 minutes. In addition of CBCs, serum glucose, basic metabolic panel, blood gas, calcium, magnesium, and medication level within 5 minutes of convulsion. What about the EEG rule in status epilepticus? Actually, the Neurocritical Care Society guideline, they are recommended to start to initiate the EEG within 15 to 60 minutes after seizure onset to evaluate non-convulsive status epilepticus, or within a baseline of 10 minutes of convulsion seizure has been stopped, or within 60 minutes of patient whose ongoing seizure are suspect. They are doing like multi-center cohort of critical ill patient. They found around 33% of patients who's having convulsive status epilepticus, and they are aborted and stay for a long time. When they are doing EEG, they found really they have ongoing convulsion, but not detected by movement. عشان كذا جدا مهم موضوع الEEG عشان not missing the patient who having non-motor feature of convulsion. What about the neuroimaging for those patients? All the guidelines and societies, they are agree we have to do the imaging, but they are like a lot of talk about the timing of imaging when I have to do the CT, for example. So the American Academy of Neurology practice, they prefer to stabilize the patient first, let the seizure aborted, then doing the neuroimaging. On other hand, the Neurocritical Care Society guideline, they are consider the neuroimaging to be done as urgent within first of 60 minutes of status epilepticus onset, regardless the abortion or aborted of convulsion. So this is a neuroimaging indication like a focal seizure, persistent alternate mental of status, sign of increased intracranial pressure, sepsis like meningitis or meningeal sign, recent head injury, hydrocephalus to rule out obstruction, history of sickle cell disease or to rule out stroke, history of cancer or bleeding disorder to rule out hemorrhage. So now we are moving to the important part for us, how we can evaluate the patient who's coming to us with the status epilepticus. So actually our role is starting not from the emergency. Our role is starting from the ambulance or from the pre-hospital care. So the patient early treatment for status epilepticus, they are found better outcome and better improvement. So early intervention, that's mean better outcome. So the pre-hospital management is associated with a shorter status epilepticus duration. So we have to learn or educate the paramedic in ambulance or Red Crescent to how to use or give him their authority to how to use like buccal midazolam and another route of benzo to control a status epilepticus. What about if patient came to us with airway compromise? We all know about RSI. We have 6P, But we are stress on induction of medication. We have ketamine. They saw and suggest ketamine as induction medication because they have like anti-epileptic effect. Also, regarding muscle paralysis or muscle or neuromuscular blocked agent like reconium because short and rapid onset. So we'll move now to the major part. We have actually two major phase of management, starting with the initial phase, which call emergent, and urgent control therapy, which call second. دائما احنا نختصرها نقول the first step with a bolus, second step with a loading, third step with infusions. So the first line of management, they are starting with a benzo. We have benzo, as we mentioned. We have lorazepam, diazepam, midazolam with different routes, with different maximum dose. We have different medication and those. But actually, there is no difference between, there is no priorities for those three medication. The benzo is stay benzo. So don't take a long time to prefer one lorazepam over the diazepam and keep the patient seizing for a long time. You have a window. We have to administrate the best rapid available benzo that you have in your emergency. So regarding the side effect, all the benzo they have the same or similar side effect regarding respiratory depression. What about the second line of management? We have almost 4 or 5 medication. We have Kibra, Dipakine, phenytoin, physphenotoin, and phenobarb. So this is a second line of management. We will start with the phenytoin and phosphenotoin. This is a loading dose with a 20 milligram per kg, usually over 30 minutes or 20 to 30 minutes. Actually, the American Epilepsy Society guideline, they show there is the efficacy almost the same, but regarding the side effect from the cardiac arrhythmia and local severe skin reaction, maybe they have with a phenytoin more than phosphenotoin. We are coming to these questions. Did the phenytoin is with a child who's presenting with a febrile status epilepticus work or not? What do you think? في أحد عنده إجابة قد قرأ articles regarding the phenytoin with a febrile status epilepticus? Actually, this is a study has been done for those patients came with a febrile status epilepticus. They are found phenytoin is rarely effective in control febrile status epilepticus. And exposure also, phenytoin, they might lead to prolonged febrile seizure and increase risk of brain injury. What about the Keppra or levetiracetam with a dose of 60 milligram per kg loading dose? Actually, the meta-analysis of drugs administration for benzo-refractory convulsion status epilepticus found levetiracetam was effective with 69%. Actually, I like Keppra because less side effect, only aggressions, might need little bit adjustment with a renal dysfunction. That's it. What about the dipakine or valproic acid? Actually, there is two meta-analysis was done regarding effective of this medication. Actually, the valproic acid is higher effective by 78% than phenytoin, phenobarbital, and levetiracetam. So the dipakine having superior regarding efficacy of status epilepticus as a second line of treatment. But when we look to the side effects like hypotension, thrombocytopenia, pancytopenia, platelet dysfunction, hypersensitivity, pancreatitis, hyperammonemia, and also there is a warning regarding the patient who's having metabolic disease, regarding hepatic toxicity. So they're having a lot of side effect. But the benefit sometimes يعني احيانا البنفيت تغلب السايد افكت هذه كلها. What about the phenobarbital? Actually, phenobarbital they have with a dose of 20 milligram per kg with a loading dose 20 or over 20 and 30 minutes. The effect around 74% to the patient. Also, phenobarbital actually we are consider him as a يعني مو يعني هو لا هو اللي هو second line ولا هو third line, هو يعتبر in between. So when patient يعني you are escalate after benzo to time and start to, for example, Kipra or Dibakine, and still patient having seizure, you can't think about the phenobarbital. طبعا السايد افكت respiratory depression the same as benzo. Now we will talk briefly about the neonatal status epilepticus لأنه في small يعني في اختلاف بسيط. There is a small difference in management. So the neonatal encephalopathy secondary to hypoxic ischemia is the most common cause of a neonatal seizure. There is like a reversible cause like infection. We have CNS infection treated with antibiotics. Hypoglycemia, we will correct it with the D10. Hypocalcemia, we will correct it with calcium gluconate. Hypomagnesemia, with the magnesium sulfate. Regarding the first line of management, actually, in the neonatal age group, we start with a phenobarbital, not benzo. So initial dose, we have a 20 milligram per kg IV to be given over 15 to 20 minutes. If necessary, we can increase it or add 10 to 20 milligram IV also until the seizure stopped. Important note that regarding the sedation, respiratory arrest, hypotension, potential complication, maybe came with phenobarbital. What about refractory status epilepticus? By definition, from the Neurocritical Care Society guidelines, this term label when patient failure to regain his baseline after first and second line that I mentioned. So what happened? Actually, we will طبعا sure we will secure the airway. We will electively intubate the patient, called ICU or PICU, to start infusions of midazolam or pentobarbital, and we have to put the patient on EEG monitoring. طبعا هذا اختصار للميديكيشنز الانيشال يعني مانجمنت سواء للستيتس ابيليبتيكس وبرضه للنيونيتال سيجر. فهوز interesting to have both of paragraph هذا في الباركود. You can scan it and keep it in your in your mind وبرضه في الجوال ما يمنع. Regarding dispositions, patients with status epilepticus, they have to be admitted to hospital. Sometime might need ICU setting when reach the second line and patients still not improve. Continuous EEG monitoring is essential for those patients and have to be monitoring for non-motor or non-convulsive motor activity. So in summary, the goal of therapy to terminate both clinical and electrical seizure activity safely and rapidly. We have a first access to maintain adequate airway. Don't forget ABC. Then should be start with the benzo with exceptional in neonatal age group. We start with phenobarbital should be given. Should be prepared for respiratory support, ventilation support with multiple dose of benzo and sometime when reached to the second or third line of management. When patient is hemodynamically stable and the clinical seizure activity has been terminated, expert consultation with the neurology should be considered and guide to decision obtain additional studies such as neuroimaging and EEG. So later on, after patient stabilize, we have to put on EEG, consultant neurology. EEG should be considered. CT plus minus MRI later on. So we are coming to the end. This is our or my references, and thank you.
Thank you, Dr. Ahmed, for this informative and very interesting presentation. If anyone has any question to Dr. Ahmed regarding pediatric and neonatal epilepsy and status epilepticus, anyone has any question?
Yes, I'm Dr. Arsalan. I would like to ask this regarding this. The people are mostly using, most of the time I've noticed that they are using diazepam and they are diluting it with the saline or distilled water or what. Is it recommendable to dilute the diazepam?
Diazepam with what?
Is it recommended to dilute the diazepam?
Diazepam as a first line of treatment? I didn't get your question clearly, please.
No, my question is very simple. My question is, are we supposed to dilute the injection diazepam or
yeah,
no?
dilute, you mean?
Dilution, yes, dilution. Ask about dilution.
Even dilute the diazepam, or you can give with a slow over 1 minute of yeah. You have you have to administrate very slowly within 30 to 1 minute.
Okay, thank you.
Any other question to Dr. Ahmed regarding to epilepsy or status epilepticus in pediatric? Okay, I think there is no more questions. So thank you Dr. Ahmed for this
يعطيكم العافية
great
جميعا.
presentation. شكرا ليك يا دكتور.
نراكم في توبيكات أخرى بإذن الله.
إن شاء الله إن شاء الله يوم الأربعاء القادم. Next Wednesday we'll have another topic. It will be regarding chest pain with Dr. Asma from King Khalid Hospital at the same time 10 o'clock. And we invite you.
If you don't mind, can I ask
yes, please.
one more thing?
Yeah.
Yes,
sure.
please.
Regarding this lecture and regarding the old lectures, we have requested many times that we should have a link so that we can review these lectures in our hospital setup
Yeah, yes,
to
we are.
update ourselves.
Yes, we are recording these lectures and we put in a YouTube channel, and I will share the link of this channel here in the Zoom, and also I will send through WhatsApp to leaders on your hospital, and they will share with you. I will put
Yes,
the link now also in the chat in the Zoom, okay?
yes, sir. It would be better if you can share in the this emergency leader group. That would be
Yes.
uh, very nice.
Yes, yes, yes. I will share now directly after the lecture. Don't go, and I will share now, okay?
Yeah. And this one and the old one also,
All
please,
all all
if
previous
possible.
one. Yes, all previous one is recorded and uploaded.
Thank you very much. Thank you very much. So nice of you.
Yes, thank you. Thank you everybody.
يا رب
And
التوفيق، شكرا لكم.
yes, شكرا دكتور أحمد. I will share the link now in the chat box. You can get the link, and inshallah, we'll have the next lecture with chest pain next Wednesday with Dr. Asma from King Khalid Hostel. Okay, thank you, everybody.
Can I ask one question?
Yes, yes,
تفضل.
yes.
I'm Dr. Inayatullah from Aburaka General Hospital. My question is, in the area like Aburaka, sometimes we don't have other medication other than diazepam or lorazepam. If the patient came with status epilepticus and we have only this medication and there is no anesthesia, so what will be our approach after
So
giving first drug?
yeah, yeah.
If still not controlled, so what will be our response?
What you have in your hospital only?
For example, we have only lorazepam or diazepam. If there is phenobarbital, no problem. But still we don't have any anesthesia. But
Yeah,
the
even
status is still not controlled. And journey
if-
we have 250 kilometers. So what we can do in such situation to save the
yeah,
life?
yeah. So from beginning, once the patient arrived to you with the status, and you are well known that you have nothing apart of benzo, you have to initiate the transfer from beginning, not waiting till reach the first 20 or 30 minutes. Then you initiate the transfer. So the patient just when came, you have 15 to 20 minutes to administrate the benzo, 2 or 3 dose. If you have phenobar, but be cautious with the airway, because might be having respiratory depression anytime, might need intubation. So under all these circumstances, you have to initiate to transfer this patient as soon as possible.
But if the tertiary care hospital is about 100 kilometers, we can take a risk. But from Aburaka to Tabuk, it is a big risk. So, and we can't do anything while we are transporting the patient. So, in this condition, can we refer to Al-Ola?
Al-Ula?
Yes.
The distance between Al-Ula and Buraka, how many kilometers?
150 kilometers, and the road is very smooth, not like
What
Aburaka
about,
to Tabuk.
no, what about Al-Wajh?
Al-Wajh, about 200 kilometers.
ضبا, يعني the nearest hospital.
Yes, nearest Al-Ola.
Uh-huh. This actually,
Yes.
the arrangement of it, يعني transfer the patient is depend on the life saving. When you are calling them, and they will direct you either inside the region, Tabuk region, or outside. So usually,
Mhm.
according to the facility and the distance is be considered.
Okay.
But we have, but if you don't have, it's supposed to be ordered from beginning. Don't say I didn't have second line of treatment and I will stay like that. We have keep order from the medical supply to provide anti-epileptic medications.
Okay.
But
Thank you.
Dr. Ahmed, if he couldn't manage maybe the patient or delayed or something like that, should and the patient in status epilepticus hypoxic and like should he proceed to third line intubation and mechanically ventilation to secure the airway for the patient?
Sure. Yeah. We can skip the second line, sure. And I'm waiting to say we have like midazolam. If they have midazolam, I will let him from the first line of management to jump to infusion directly. Give him loading, then infusion and secure airway, intubate the patient and transfer him
Safe,
safe.
yes.
Yeah, but if the facility is only available benzodiazepam, that's it. It's difficult to keep the patient like that.
Because actually this happened to me one time. So we were referring to Tabuk, and after 20 minutes journey, the patient deteriorated. And as SP2 dropped to 60%, and he was very in a serious condition. After that, we'd come back to the hospital. We gave him a bit more diazepam. After that, we refer to Alola.
Mm-hmm. Yeah, sometimes
And the
they
patient
like
was
having.
still convulsing.
Yeah, I know. Sometimes they are having like this is out of our hand sometimes. But when we prepare ourselves and prepare our ER department to face like those scenarios, the outcome will be better.
Thanks, Dr. Ahmed. Any other question for Dr. Ahmed? Okay. If no more questions, okay, thank you, Dr. Ahmed, very much. Please register in the link here because we will send the certificates also for attendance. Register in the Google link and you will find the YouTube channel. We will upload today also this lecture for Dr. Ahmed after finishing this lecture, inshallah. Thank you, everybody. You are all welcome to share with us, even with attending, even with sharing, as who is interested to give a lecture or participate in any activities, scientific activities. As Dr. Ahmed said, we are accepted in the emergency board, but this is the first step. Actually, the real step is to keep a high quality education. Yes.
ما فيش.
Okay. Thank you, everybody. Inshallah, see you next week. Thank you.
شكرا خير، مع السلامة.
سلام.
طب بص انا هبعتهولك انا مش شايف ازاي.
واحد واقف لي كده قدام الباب، اول ما شافني انت يا دكتور بطنيه، ايوه نعم، قلت له لا استنى ما اشوف الاول الدكتور ما يكونش هو